So let's talk about clinical therapy and how we treat pediatric pain. First of all, the most common methods of treating pediatric pain, NSAIDs and acetaminophen, would be our first pass for mild to moderate pain or chronic pain management, such as those with sickle cell disease or cancer that was of a mild or moderate nature. Remember that acetaminophen does not have an anti-inflammatory property. And therefore will not have that additional support for pain management. NSAIDs are often given in combination with opioids because they potentiate the effectiveness of that opioid. Opioids are used for severe pain just as we would use with adults. Oral and IV is the best route for children, and it is preferred. Oral opioids can be just as effective as IM and IV opioids as long as their dosing is managed appropriately. We would much prefer to not cause additional pain and stress to treat pain that already exists. So it's always better to give it oral or IV rather than IM. We know this opioid side effects. In particular, one thing I want you to remember is with opioids, everything slows down. So we get constipated, our urine output drops, our thought processes can be a little bit slowed down. So we're unsafe walking and maneuvering. Our respiratory status slows down and we get depression in our respiratory status. It can happen very rapidly in children and warrants our very close attention and monitoring. There is a physical dependence that can happen with opioids, as you recall from pharmacology in adult populations. The same thing can happen in pediatric populations. We monitor them for signs and symptoms of withdrawal, as well as signs and symptoms of a tolerance that has developed, and we will treat accordingly. Children who have been on opioids for a longer period of time will be weaned just as we would with the adult population. There are additional ways that we can give drug therapies to pediatric patients. PCAs are very effective for children 6 years and up, although we have used it with some children a little bit younger. It is dependent on the developmental level and understanding of that child. They must be able to use a self-reporting scale for pain in order to use a PCA. And that's why we're usually looking at least 6 years of age. Sometimes nurses will be able to control PCA usage. We used to try it, and there had been some research done having parents push the button for their kids, but that has been removed, and most hospitals will not do that anymore. Regional pain management, like an epidural or nerve blocks that we would do in the adult population, can also be done in the pediatric population with proper dosing and can be very effective for regional types of pain management. Now, in conjunction with giving medications, it's incredibly important to remember there are a lot of non-pharmacologic methods of pain management that are very effective with children. At the very minimum, we should be using those in conjunction with pain or with medication management. But in some cases, some of this non-pharmacology treatment can be better and more effective and not warrant heavy dosing for medications. So the first thing is distraction, one of the most effective things we can use with children. Teaching parents how to do that and engage them in other pleasant activities can help relieve a child of pain. With severe pain, this will not be effective. Guided imagery is just as it said. We all know what that is. This works very well with school-age children who have the capacity to kind of think through those thoughts and put that together and in terms of focusing on those vivid images. Relaxation techniques, teaching children how to tense up a muscle and relax a muscle, and once they can understand the differences in how that feels, it can be very effective to help them learn how to go through a muscle relaxing technique. We can combine that even more effectively with breathing techniques, teaching children how to breathe in deep, hold it, and let it release. With little children, we can teach that through blowing bubbles. We can teach that by blowing cotton balls, anything to try to get them to learn that controlled breathing technique, because that is incredibly effective, especially when combined with relaxation and imagery. Cutaneous stimulation or the use of gentle rubbing or touch. That generally works on the premise that we are blocking nerve impulses. And this can be really effective. The touching will compete with that painful stimuli in children, and holding and rocking, it can be as simple as that. Neonates, that's one of the reasons we do skin-to-skin contact. and holding and swaddling. Those types of things provide a nice touch and pressure that can alleviate pain. Hypnosis. We all know what hypnosis is. Children respond much better to this than adults do. Children, remember, many of them have that imaginative side to them. They have the ability, they have no limitations, if you will. They don't think through the limitations. They actually function in a world of imagination and fantasy. And hypnosis can be incredibly effective in children for pain management. Sucrose solution, or Sweetums, actually is a solution that is a sugar solution. Infants love the taste of it. We use this in either preterm or newborn infants up until about the age of 1 month. We will give them this solution orally, and it will cause them to suck. But it will also activate endogenous opioid pathways that will lead to the release of endogenous opioids. It works very well up until about the age of 4 weeks, and it's quick. So we need to make sure that we give the solution about 2 minutes before the desired procedure, like maybe a heel stick for blood, a circumcision. Go ahead and do that, and it will last for about 5 minutes through the procedure, and is very effective. If we continue to have the child suck, like on a binky, it will potentiate or make the effects last longer. There are a few more. Heat and cold is really incredibly effective. Heat can be used in the later stages. In that first 24 hours, we don't want to do anything that will cause vasodilation to an area of injury or pain. We want to be sure there's no potential for bleeding in a site, or there's no swelling and inflammation, because adding heat will cause greater vasodilation into that area. Additionally, when it's an injury that has caused that sort of pain, we want to ice first. Ice will cause vasoconstriction, will limit bleeding and swelling to an area. Once the first 24 hours is up, then we will go ahead, and as long as there's no edema or swelling present, we will go ahead and switch to the heat. TENS units, or electroanalgesia, can be very effective. It is the use of electrical stimulation on the surface of the skin. Electrodes, just like you can see that picture, are just stuck to the skin, almost like a cardiac electrode or cardiac monitor device. And really what this does is sticks to the skin and then gives a little bit of an impulse to the nerves in that particular area around the injury, and it will actually complete and block the pain transmission. I have used this for an injury I had. It's very effective. These can either be used through the recommendation, order, and coordination with a physical therapy team, or there are small units over the counter. So if you have a knee injury, or you've pulled a muscle running or exercising, some of the over-the-counter methods can be very effective in the short term for minor injuries. Acupuncture is the final method that we could talk about. In children, this is really very limited research. Culturally, there may be cultures that may use this much more readily and openly, but overall is not something we are using in children. We may try to use in adolescents if there has been some exposure to that.